Hi guys, welcome back. The next topic we're studying is congestive heart failure. I'll be explaining to you regarding reasons behind development of bat-wing pulmonary edema. But before I talk about the radiological aspect and diagnosis of congestive heart failure, I would like to focus on some baseline information as well. You are familiar about the fact that cardiac output per se is a product of heart rate multiplied by stroke volume. And in this chart, because the stroke volume will become lesser, so by compensation, the heart rate will dramatically increase, which explains the fact that why a large number of patients of congestive heart failure will simply tell you, the doctor, I can feel my heart racing in my chest or development of palpitations. The same sympathomimetic drive which is upgraded in the body of this person will also be responsible for excessive sweating. The air conditioning in your casualty or in your ward is working just fine, but this guy will be having big beads of sweat on his forehead, so this excessive sweating would be referred to as diaphoresis. Both feature number 1 and 2 are explained by the increased sympathomimetic drive, whereas 3, 4, 5 that I'll explain to you will be because of pulmonary edema. You see, if the left ventricle will not work properly, the person will start experiencing breathlessness on exertion. In fact, it might increase to even breathlessness or dyspnea on rest, and in some cases, the patient might never reach the hospital. If you have seen a case of left ventricular failure deteriorating before you, you will notice that it happens very fast, and the person starts developing even a pink frothy sputum, which is going to be fairly alarming for the family members. In the retrospective, you will also come to know that this person was not sleeping well for past couple of days. There are two reasons why a person of congestive heart failure will not be sleeping well. One would be the pulmonary edema component that is worsened in supine position. See, if he writes classical terms like paroxysmal nocturnal dyspnea, or if he incorporates words like orthopnea, then obviously the question will be a piece of cake for you. So instead of that, he might actually describe nocturnal cough in a patient in the sense that the pulmonary edema component will irritate the J receptors in the lungs, so the cough can be initiated. Over and above this, another reason why the sleep can be disturbed is because the body is trying to now compensate for this heart failure by producing excess amount of BNP. You're aware of B-type natriuretic peptide, which is produced by our ventricles, but in this chart, because there is a rather stretching of the ventricles much more than normal, so BNP will cause natriuresis, salt loss, and water loss from the body, and that will explain the nocturia in these patients. The pulmonary edema is anyway worsened in supine position. Since the forward failure component will also be there, this person will say that climbing stairs has become a Herculean task for me. This person says that earlier I could go up and down the stairs of my house, I could carry some weight also, I could carry vegetables from the market, I could go to the grocery shop, carry 10 kgs of grocery on my shoulder without any problem, but now even going once or twice up and down the stairs is a Herculean task for me, and some people will totally be incapable of doing any such activity, especially in acute congestive heart failure. Feature number 1 and 2 is due to sympathomimetic drive, and 3 onwards are mainly because of the pulmonary edema component. 6 is because of forward failure developing in this chart. Now let us look at what will be the examination findings in a person of congestive heart failure. The reason for congestive heart failure can be manifold. It could be dilated cardiomyopathy, it could be restrictive cardiomyopathy, it could be ischemic cardiomyopathy, like triple vessel disease present in a patient, he did not get surgery done, so the ischemia of the heart on a long-term basis will cause rather one of the form of cardiomyopathies which is very difficult to treat and patients die within a couple of months or years, that is ischemic cardiomyopathy. Let us have a look at the examination findings that you will find in this person, and if he says what is one of the early signs in CHF, answer is tachycardia. When I'm describing the tachycardia component, it also gives me an opportunity to explain to you from physiology that what is the maximum heart rate possible for a normal human being. Let me give an example here. Like you have a young guy, 20-25 years of age, he says, Doc, how hard can I run on a treadmill? You see, nowadays the treadmills that are available, they might be having sensors that you can put to your chest and do some running, and sometimes these sensors might be running via Bluetooth also, and the machine will give you a display that this is your heart rate when you're running on the treadmill. The maximum heart rate possible for a normal human being is 220 minus age. Why I'm saying that physiological heart rate upper limit is because somebody is 20 years of age, he can work out so hard that heart rate is 200, nothing will happen to him. But if a 60-year-old man is having a heart rate of 200, that is not physiological, guys, it is pathological because of increased sympathomimetic drive. And when you increase the heart rate to such dramatically high values, it will increase the oxygen consumption of the heart, and coronary arteries may not be in a position to supply that oxygen supply. So ultimately, what will the poor heart do? It will fail, it will stop working, it will not be able to do optimal performance. I tried to explain to you the difference between physiological and pathological tachycardia. I said if somebody is 20 years of age, 200 is physiological. But at 60, 200 is not physiological, it is pathological. If the heart is beating that fast, there has to be a reason behind it, and one of that is congestive heart failure. The heart is beating fast. Why? Because it is trying to clear the pulmonary edema component. Now, person can develop left ventricular failure, person can develop right ventricular failure, or a combo of the two called as biventricular failure. If the left side will fail, obviously the systolic blood pressure will dramatically start reducing, and the blood supply to kidney will also be less if BP is less, so there would be oliguria developing in the patient. In fact, that is bad news, because multi-organ failure can start, heart is not working, and then kidneys will also stop working. In congestive heart failure, the ventricular cavity gets dilated. When I say the word failure, the image in your mind should be that the heart is not able to do its job, so the poor hypoxic heart is dilated. It's making a sad face, it's dilated. Now, the dilated ventricles can be having a turbulence. When blood comes into the dilated ventricles, during the filling phase, it will create a turbulence. This turbulence is what is called as ventricular gallop rhythm. I have explained in the heart sound section that atrial gallop is S4 and third heart sound is called as ventricular gallop. It is primarily because of the turbulence created when blood comes into a dilated ventricle, a failing dilated ventricle. The fourth feature is a characteristic feature of left ventricular failure. I mean, if you read the statement that I'm writing before you at the moment, it is 100% left ventricular failure, bilateral fine crackles. Instead of crackles, he might say crepitations. The sound produced will be like when you open a Velcro tape. I mean, I'm not talking about the intensity. I'm talking about the pitch, the character of the sound, that kind of sound that you will hear, that when you open a Velcro tape, that sudden scratching sound that would come is akin to what is going to be found with respect to heart failure patients. Obviously, in lesser intensity, fine crackles are occurring because of fluid in the alveoli. The fifth feature, before I write it down, I would just like to give you a short description of it. So please have a look at the board. Please stop taking notes at the moment and listen to what I'm saying. I have here shown the configuration of the pleural reflection. This is the costophrenic angle, and superiorly will be the cardiophrenic angle, and as the heart fails, there is always a development of a pleural effusion of the bilateral variety. Due to gravity, the fluid will first obviously obliterate the costophrenic angle, so it will appear white on a chest X-ray. As the fluid will increase further, it will also cause obliteration of the cardiophrenic angle, and now the fluid is increasing substantially. So what I have done is just to dramatize the effect of a pleural effusion bilaterally present in congestive heart failure. I have shown here fluid, which is shown in color yellow, pressing. If this is transudative fluid, it is pressing on the lung parenchyma from outside. Now, if you put your stethoscope over this area where there is fluid pressing over the lung, then the breath sound intensity will be dramatically reduced. I repeat again, this fluid pressing on the lungs from outside. Obviously, the lung bases are the ones which are going to be first affected, and then the level of the fluid will rise. But initially, in the lower part of the lungs, especially inframammary, infraaxillary areas, there will be reduced intensity of breath sounds, and that is part number 5 here. I repeat the fact once again. Why does he write in congestive heart failure MCQ? A bilateral reduction of air entry is because of bilateral pleural effusion of the transudative variety that will develop in this case. In some MCQs, just to trouble you and make it sound sophisticated, he might even use the word reduction in vital capacity. You are aware vital capacity is the sum of expiratory reserve volume plus tidal volume plus inspiratory reserve volume. You add all three, that is vital capacity, so that would obviously be lesser. The point I'm trying to make is he can put up a question saying all are features of left ventricular failure except, and he can put up one feature of right ventricular failure, or he could ask you to select multiple correct options. Well, if he says what is the most common cause of a development of right ventricular failure in a patient, then the blame is on the left. It is left because both sides are coupled. No, left will fail, right will automatically fail. And when the right ventricle will fail, it will result in elevated jugular venous pressure. To make the question look a little sophisticated, he might actually put up the word small sign instead of elevated JVP, because he wants to see that you know the fact that in a normal person on inspiration, JVP falls. But in this patient, because the heart is failing, there is no space in the heart, it is grossly dilated, the column will not be able to fall. In fact, it might even rise. If a JVP column tends to rise on inspiration, normal physiologically it should fall. If it rises on inspiration, we tend to call it small sign. In some MCQs, instead of writing these two, he might even write the word positive abdominojugular reflux. It basically means that when you're pressing in the right upper quadrant of this patient, you are pressing the blood of the liver towards the heart. If I press on your liver for 10 seconds and let it go, the extra blood of your liver will be squeezed towards your heart via the great veins, and because your heart has sufficient amount of space, it is compliant, it is able to function well, it will be able to welcome all the extra blood. But if I try to do this in a heart failure patient, I pressed on the lever for 10 seconds, let it go. The extra blood will go towards the non-compliant ventricle. This ventricle will not be happy about and cannot, in fact, forget about happy. It just cannot receive extra blood. So what will the blood do? It will regurgitate into the jugular veins. So when I say the word positive abdominal jugular reflux, it simply tells you that the compliance of the ventricle, especially the right side, is hampered. Point number A and B basically are the same. Right side is failing. It is just different ways of expression. The next feature will be encountered in acute variety of heart failure. When there is a sudden stretching of the capsule of the liver, there will be a pain in the right upper quadrant, right upper quadrant, fullness, tenderness, that is tender hepatomegaly. As the patient will go into chronic heart failure, in chronic heart failure, there will be a development of the pitting variety of pedal edema. In fact, this is itself a question. Pedal edema is not seen in acute congestive heart failure. Please remember pitting variety of pedal edema, because obviously it will take some time to happen. No? So the pedal edema is always going to be encountered in the chronic variety. It is not going to be encountered in the acute variety because time is very less. I'm just putting across to here to say that a pitting variety of pedal edema. Pedal edema is always pitting in heart failure. The point is pedal edema per se, ankle edema per se, is not going to be encountered in persons of acute congestive heart failure. Now, all these points that I've explained to you at the moment are including the symptoms that I highlighted initially, and then I mentioned a couple of signs. When you will read the textbook regarding congestive heart failure topic, you will always read about a criteria which is called as Framingham criteria, not Framingham heart risk score. Let me just jot it down. What I am saying is everything that I've discussed with you with respect to the signs and symptoms, that is called as Framingham criteria for diagnosis of congestive heart failure. Now, obviously, when you say criteria, there are going to be major criteria and minor criteria. So let's look at which are the minor ones. And I'm going to just put some pointers here with respect to the minor ones. One of them is tender hepatomegaly. Why? Well, hepatomegaly can be found in amoebic liver abscess. It can be found in viral hepatitis. So it's no big deal that you are getting hepatomegaly in a person. It can be congestive heart failure only. There can be other differential diagnosis also. Similarly, pitting pedal edema. See, you doctors might be listening to so many lectures for 10 hours, 12 hours every day. If you're sitting on a table and a chair with your legs dangling, you might develop edema also. Especially obese people will have more chances of developing pedal edema. Pedal edema can be found even in cirrhosis. So there is no big deal about pitting variety of pedal edema for heart failure because it can be found in other conditions also. Similarly, if I talk about a bilateral pleural effusion of the transudative variety, bilateral pleural effusion of the transudative variety can even be found in cirrhosis, even in patients of nephrotic syndrome. So I'm putting some pointers here to say that some of the features, like for example, if I say tachycardia, if 5 questions in the exam serially go wrong, or you are not aware of, you are not even read the topics, you will start having palpitations in the exam and your heart will start beating faster. So tachycardia can occur due to anxiety, it can occur due to Graves' disease, it occurs in anemia. So what I'm trying to say is that you don't need to cram the data. It is simply the fact that when I say somebody is having bilateral fine crackles, it means that left ventricle is failing. When I say positive abdominal jugular reflex, it means right ventricle is failing. Those are major ones, but the ones that put star marks again, or let me say even oliguria, let me say hypotension, I said there's no need to cram and there's no need to actually get into which are major and which are minor ones. It is simply the fact that the question that you need to ask to yourself is this finding gonna be seen in anything apart from heart failure? Like for example, if I say person is having positive abdominal jugular reflex, obviously it's a feature of heart failure. No, it's specific for heart failure in contrast to something like a hepatomegaly or a pedal edema. So the message here is that for diagnosis, you need 2 major criteria. 2 major criteria can be like fine crackles in the chest, along with that third heart sound could be developing in the person as well. But just like Jones criteria, you just need to operate them. It could be 1 major and 2 minor criteria developing in the patient, like especially if it is going to be let me say right heart failure, then there could be concomitant hepatomegaly and an ankle edema developing in the patient. Obviously it will take time and the hepatomegaly may not be tender in the chronic variety. Only tender hepatomegaly is a feature of the acute variety. So at this junction, first of all, I want you to be very comfortable with this term, that is Framingham criteria. And what they do in the exam is, because they know that we are in the rush to answer. So because we are trying to rush into answers there, they can deliberately change the language of the question as Framingham heart risk calculator. To explain Framingham heart risk calculator, I would first like to mention that our former cricket captain Saurav Ganguly ji, he also had a cardiac event. No, he's only 48 years of age. He became the president of BCCI and was also trying politics, etc. But the point is, he was a fit guy, no? And so to be captain of an Indian cricket team, he had to be fit in his best age. No, he's only 48. He had a cardiac event. And the cardiac event was that he was running on the treadmill in his house and he started having this chest pain and heaviness. And luckily, he reached the hospital on time. It was found that he was having a blockage in one of his coronary artery. In fact, it was more than one blockage. He had to undergo stenting. The message is Saurav Ganguly had a history of premature coronary artery disease in his family. So if you have somebody who tells you that my father had MI when he was 55, my mama had MI when she was, let me say, only 50, non-diabetic parents, and had premature heart disease. You can do this Framingham heart risk calculator. This is available online. You can, at the moment while listening to me, you can just move on to Google and in the search bar, search for this term, Framingham heart risk calculator. There are a couple of parameters. You'll have to put in age of the patient, cigarette smoking, yes, no, blood pressure, on hypertension medication or not, what is the cholesterol values per se. The point is Framingham heart risk calculator can calculate the chances of development. I repeat the statement, this calculator has been developed to determine the chances of determining a coronary event, and considering the way coronary artery disease is increasing in India, when Kapil Dev, right, he developed it in his 60s. Saurav Ganguly has had cardiac event at 48. Anybody above more than 40 years of age, I mean, that's just an offhand remark. Anybody above 40 years of age in an Indian scenario should ideally be evaluated using a Framingham heart risk criteria to find out what are the percentage of chances that a person might be developing coronary events. Coronary events is a broad term. It could be unstable angina, principal angina, any of the two varieties of MI, STEMI, non-ST elevation MI. But if you know that the chances are high, at least you could put the person on statins. At least you could put the person on some lifestyle modification to reduce the incidence of heart disease in the patient. So this score per se will calculate the chances or development of a cardiac event in the next 10 years. It will calculate the next 10-year risk. I shall now be explaining to you regarding a workup of a patient of congestive heart failure and the treatment plan that we will work out for this person. But before I actually enumerate each of these, we also need to study the natural history of the evolution of the disease, because our answer will be proportional to what stage of congestive heart failure the patient is in. Well, I'll create a worst case scenario for you. The worst case scenario is that the person is suffering from refractory congestive heart failure. What I mean is a medically refractory CHF. Like example is a case of dilated cardiomyopathy. We have already used best of the drugs for this person. We have already used CRT, that is cardiac resynchronization therapy, because in dilated cardiomyopathy, left and right ventricle may not fire at the same time. So non-synchronous activity will contribute to pulmonary edema. CRT will ensure simultaneous contraction. Everything possible has been done. The only thing left for this particular person is now cardiac transplantation. And well, from Indian perspective, cardiac transplantation is obviously not only economically challenging, logistics wise is also challenging, and lots of time patient's family and the government may not have sufficient funds to ensure a cardiac transplantation in a person, so this person will expire. In contrast, when you look at stage B versus stage C, both patients are having a structural heart disease. Let us say both of these patients are having ischemic cardiomyopathy. Both of these patients were told that they are having triple vessel disease. They should be taking or undergoing a coronary artery bypass grafting, but they decided to go to homeopathic, Ayurvedic, etc. And if they are definitely not going to take the medical treatment that we offer, these patients will deteriorate to the level that in stage C, signs and symptoms of congestive heart failure will develop in the person, all the signs and symptoms that I explained to you earlier. But when it comes to stage B, at the moment the guy is lucky, there are no signs and symptoms, he will develop them in future. Whereas when it comes to stage A of CHF, it means that there is no structural heart disease in a patient, but risk factors are present. What I mean by risk factors present is like he is having daily alcohol intake. You are aware that daily alcohol intake will cause dilated cardiomyopathy, or he is having premature coronary artery disease in his family. The history is present, like his father had MI at maybe 55 years of age or maybe even younger. So our treatment will be based on which stage the patient is in. And anyway, we need to do a workup, and one of the simple investigations that we will do in the casualty will be a chest x-ray, which will right away show you cardiomegaly. You can notice a substantial increase in the CT ratio of this person, which is because the heart is failing, and along with that, battling pulmonary edema can be appreciated. In fact, how the radiological findings will develop, I'll show you by hand drawing the radiological findings also subsequently. But usually the image that you will see in the casualty will be the one that I've just highlighted. And the query that comes at the moment is that, sir, we have seen this kind of an X-ray which is wide bilaterally, and we might be having a plus minus CT ratio of increase versus normal. And in those circumstances, how do we differentiate whether it is cardiogenic or non-cardiogenic pulmonary edema? Because in COVID-19, there is ARDS occurring in a patient. So therefore, I can put this in fact as an important question for today, that what blood test will help you differentiate whether it is a cardiogenic pulmonary edema or a non-cardiogenic pulmonary edema? Well, the test that I can do in the patient is BNP, B-type natriuretic peptide, though in the exam he might write the full long literature-wise data, that is N-terminal pro BNP. This BNP is being released due to the volume overloading of the ventricles. If you read that the value is elevated, you are not supposed to remember cutoffs per se, that I'm just putting for academic reasons. But otherwise, if BNP levels are elevated, it indicates that the person is having a cardiogenic pulmonary edema, and we can easily differentiate it from a non-cardiogenic pulmonary edema. In fact, I'll give one more example, that is from hematology. You will notice that in the hemat section with blood transfusion components, I have talked about TACO and TRALI. TACO is transfusion associated circulatory overload. TACO is a cardiogenic pulmonary edema, whereas TRALI, transfusion related acute lung injury, is a non-cardiogenic pulmonary edema. So to differentiate TRALI versus TACO, we will be doing again BNP levels. If it is elevated, it is TACO. If they're normal, it is TRALI, because X-ray picture may not be very clear. The X-ray picture will obviously show you evidence of cardiomegaly in the cardiogenic variety, but I'm saying in early onset, the CT ratio might be normal, the heart may not have grossly dilated. So only X-ray cannot be useful for diagnosis. We need evidence, and one of the very good evidence for congestive heart failure is values of N-terminal pro-BNP. So now I will sketch before you the cardiac borders, and we will then be evaluating how the X-ray of the person will look like. I've shown the cardiac borders here with respect to the aortic knuckle, then the pulmonary artery segment, left atrial appendage and left ventricle, and this is going to be the right atria and SVC and IVC inferiorly. See, the initial finding that will develop in any patient of congestive cardiac failure will be prominent upper lobe veins, and in the MCQ he will deliberately write prominent lower lobe veins. I want you to remember this statement of mine, very important from the exam perspective. A lot of us in exam stress, pressure cooker situation, there might be errors of judgment. If you don't read, this might cause an error. I said it's prominent upper lobe veins. These are the pulmonary veins, which are looping into the left side of the heart, that's the left atrium, because the heart is failing, especially the left ventricular failure here. So the pulmonary veins will become relatively more prominent, and that's the statement that is present here, called as antler sign. It looks like horns on the head of an animal. So if he uses a classical word antler sign, then it is unlikely to be missed by anybody. If he says the word reverse mustache sign, then again it is unlikely to be missed up by anybody. Therefore, the examiner may actually just say the word prominent upper lobe veins, and as I told you, he might deliberately write prominent lower lobe veins in a except MCQ. It is only later that when the heart will begin to dilate, that the CT ratio of the patient will definitely change, and if it is left ventricular failure, then especially the apex will be going a little laterally and inferiorly. As the pressure in the heart begins to increase, that is when the fluid will start leaking out of these blood vessels into the lung parenchyma, and that is when the classical bat wing appearance will start coming. That is, I can also casually say the word, as the fluid will start leaking out of these blood vessels, there can also be a development of what we say as Selhout sign. Selhout sign basically means that cardiac borders cannot be evaluated. Let me just jot down the important features before you. I said prominent upper lobe veins would be coming. The CT ratio of the patient will dramatically increase. The value should be more than 0.5 for children. It should be more than 0.6. It is subsequently or later that the bat wing edema will develop, and sometimes this bat wing edema may not be very characteristic. Though I'm putting up a question to you at the moment, in which lung condition do you have a reverse bat wing edema? The question is open, reverse bat wing edema, while I complete the information. As the disease will progress, you will also be having a bilateral variety of pleural effusion developing in the person, and because of this, the CP angle of the two sides will start looking white. In fact, in the X-ray that I showed initially, the CP angles were not clearly decipherable. That would be very easy to rather identify it as heart failure if you have all the findings present. But these findings take some hours to develop. So if the person comes early, there might be a benefit or doubt in your mind. So it's always good to do a blood test in the patient, that is measurement of the BNP values. Another very classical radiological finding that they love to ask is curly B lines. I'm going to mention regarding curly A and curly C also, but at the moment the word is curly B lines are present where? When I asked this in a face-to-face class, lots of students casually say, sir, curly B lines are on the base of the heart, but that is not the case. Curly B lines are actually prominent pulmonary veins only. These veins are already present, but they become prominent, and look at, I have drawn them perpendicular to the pleural surface. They point to the base of the heart. Again, repeat the statement. They are not on the base. They point towards the base of the heart. This that I have highlighted before you are curly B lines, and that should not be confused with what is called as curly C lines and curly A lines. Curly A lines are present near the hilum. Alphabet A here highlights presence of curly A lines, perihilar shadows, and curly C lines are the ones which are present towards the lung bases. I have just put alphabets here to say what are the sites where you check for curly A versus curly B versus curly C. I repeat the fact, curly A are going to be located in the perihilar areas, and they represent the dilatation of the lymphatics. The congestion will occur in the venous circuit, so congestion will occur in the lymphatics also, and the anastomotic channels. Curly B lines are the ones which are perpendicular to the pleural surface, though I've already jotted it down, but just to reinforce this, I've written it again. And curly C, the word will be written in the radiology lecture as reticular opacities at lung base. Now you will read about reticular opacities also in interstitial lung disease, right? You read about honeycombing of the lung and the multiple other features of interstitial lung disease. But here I just want to highlight that the finding curly C line is going to be located at the lung base per se. So curly B points towards the lung base. That's the main message that I have highlighted before you. The data in red is for curly A, B and C lines, and also I can incorporate this MCQ reverse bat wing edema. That's a very characteristic MCQ once again, guys. So I gave you sufficient time to actually recall, and if you've read respiratory, though there are multiple causes of it, one of the important ones to be remembered is chronic eosinophilic pneumonia. You see, sometimes they love to ask about these classical terminologies. That is why I'm speaking about them. Another such question that can be asked is regarding Moustache sign. I just taught you regarding reverse Moustache sign in pulmonary edema, but Moustache sign is what you're going to be calling as gas under diaphragm. Gas under diaphragm is also referred as pneumoperitoneum. This will occur due to usually peptic ulcer disease anteriorly present that will perforate. But these are some classical radiological findings which I have just spoken before you at the moment. From the exam perspective, also remember curly B lines may be present even without congestive heart failure. In fact, one of my students after one of the previous year's papers told me that, sir, the question in radiology was curly B lines are seen in, there was no congestive heart failure in the options, then the answer would be given as lymphangitis carcinomatosis. A lot of information that I mentioned on this particular slide has an overlap with radiology. I want you to be very thorough with the radiological findings that I've highlighted. And overall, as I said, X-ray findings might take some time to evolve. The cardiomegaly component may not be visible initially. So pro-BNP levels will definitely help you in identifying the diagnosis of this condition, following which you shall be doing an echocardiography to differentiate between systolic and diastolic malfunction. One of the important parameters that you will always be studying on echocardiography will be the ejection fraction of the patient. The mathematical formula for that will be stroke volume divided by end diastolic volume. I'll just put in normal values here. The stroke volume for you and me is 80 ml and diastolic volume is 130 ml, and if you divide them, you can have a mathematical value 65%. Now, if I say a person is having systolic malfunction, that's relatively easy to understand. In systolic malfunction, the stroke volume will be less than 80 ml. So therefore, the mathematical value of ejection fraction will become less than 65. But let us now take up a person who's having hypertension. In patients who are having hypertension, there will be a diastolic malfunction of the heart. In all patients of hypertension, because there is a left ventricular hypertrophy, it will cause an increase of left ventricular end diastolic pressure. If you increase the left ventricular end diastolic pressure, then blood will not be able to fill in the left ventricles properly. If the blood is not able to fill in the left ventricles, they can definitely be pooling of blood in the lungs, explaining the pulmonary edema component. See, what I said was, if the end diastolic pressure is elevated, there will be less blood coming inside the left ventricle of a person with hypertension. If less blood will come inside the ventricles, then obviously less will go out also. Now look at the mathematics once again, though it will look very primitive to you. I said ejection fraction is stroke volume divided by end diastolic volume. If mathematically numerator will also reduce and denominator will also reduce, the stroke volume of the patient is less. End diastolic volume is also lesser. If both reduce by the same magnitude, the ejection fraction of the patient may be normal. And when you tell this to your patient that your ejection fraction is normal but you're having features of heart failure, he looks at you and says, "Sir, are you serious? My report is normal and you're telling me that there is a problem with my breathing because of my heart is not functioning." See, you guys are technical people, you can understand this, that if there is a diastolic malfunction of the heart, there's gonna be pooling of blood in the lungs that will explain the pulmonary edema. But try explaining this to a non-medico. The first query will be, if a report is normal, then how can you say heart is failing? In fact, I give you one more scenario. If suppose, this is purely mathematical, suppose the fall of denominator and diastolic volume is decreasing more in magnitude. If denominator is reduced more than the numerator, it can happen mathematically. Numerator, denominator both equal reduce, denominator a little more reduce as compared to the numerator, then mathematically this ratio might be even more than normal. Please appreciate that in diastolic malfunction, ejection fraction report can be normal or even increased, and a non-medico is literally ready to fight with you, saying, "Sir, are you serious? You're telling me I have heart failure. My report is normal. In fact, it is good. It is more than normal." You see, you guys are technical people. You can understand diastolic malfunction means pooling of blood in the lungs. What I'm trying to explain here is that echocardiography is a very good technique to identify heart failure, but is not the best. So if they ask you what is the preferred imaging modality in congestive heart failure, as of now, the best way to evaluate congestive heart failure when it comes to imaging per se is cardiac MRI. The advantages of cardiac MRI are manifold. It will not only help you pick up the types of malfunction, that is, it will help you systolic versus diastolic malfunction, true, but it will help you in determining etiology also. Like, let us take a scenario where a person is having fibrosis in the myocardium due to radiation exposure or any connective tissue disorder. There's another person who's having ischemic hypokinesia. It is ischemia, which is because of triple vessel disease, or let me say double vessel disease, did not undergo stenting, did not take medications regularly. Then ischemic hypokinesia will be segmental in some part, like whichever blood vessel is blocked. No? Like suppose right coronary artery is affected, then it will be right-sided. That is, right ventricle function will be relatively lesser. Or you can pick up even grossly dilated heart. You can pick up HOCM, no? Because thickness of the heart is more in HOCM, thickness of the heart is lesser in dilated cardiomyopathy. So this investigation, I would say, is best to evaluate three things: the type of heart failure, systolic versus diastolic, the etiology, and the prognosis. So if in the exam they ask you which is the preferred imaging modality, you see, congestive heart failure diagnosis is based on multiple facts. It is combination of Framingham criteria plus the blood test. Because if you say heart failure, sometimes you might be having a false positive report also. I want to be sure, so I'll do a BNP level, I'll do X-ray, I'll do a echo, I'll do all of these investigations, and out of these, I have to obviously select one from the perspective of imaging. Then the answer will be given as cardiac MRI. Over and above this, we also have a scale which can be filled up in consultation with the patient. I mean, how hard difficulty are you having with respect to breathing? Like, I'll put it like this. Suppose you are running on the treadmill and I hand you over the phone and say, okay, talk on the phone. If you're running very hard, you will be having breathing difficulty. No? You can't talk on the phone then. So I'll ask the patient, okay, how breathless you are. Can you talk on the phone when you are feeling breathless? He'll say, no, sir, I can't do that. So that means the disability is more. So Borg scale is basically a scale that is filled by doctor / patient. I mean, usually will be a doctor because patient is too sick. But in consultation with the patient, like you are asking him to grade the severity of his symptoms, and that can obviously a bias. If somebody is very sick, he might give you approximate answers. But functional assessment, I basically mean is that with help of cooperation of the patient, you're trying to gauge how severe the disease is. Now, on the basis of all this information, I would like to mention regarding a term which is written in the MCQ as HFPEF. HFPEF is called as heart failure with preserved ejection fraction, and the moment I describe this heart failure with preserved ejection fraction, the usual query of majority of doctors is that, sir, how is it possible that heart failure is there and still there is preserved ejection fraction? Well, first of all, I want to tell you that here I'm not saying that ejection fraction is going to be 65%. Preserved ejection fraction here simply means that person can walk into your OPD but will say that I have breathless on, let me say, climbing stairs. Preserved ejection fraction basically means that the ejection fraction of the patient is at least 50% or more. Please remember, HFrEF is heart failure with reduced ejection fraction. I'll tell you the cutoff for that also. But preserved ejection fraction does not mean an ejection fraction of normal 65%. It means an ejection fraction of 50% or more. Well, when do you get such situations? The best example of this is hypertension, because I said in hypertension, if there's a hypertrophy and increase of left ventricular endostolic pressure, if less will come in, less will go out also. So both values might proportionately reduce. The value can be turning out to be normal as well in early onset hypertension. Later on, obviously, the ejection fraction will be becoming lesser. Other examples can be restrictive cardiomyopathy. Now it is up to him. He might give you a case where a lady was having the recurrence of breast cancer. She was given radiation for this recurrence of breast cancer, and the good news is the cancer was still killed. But then radiation to the chest will damage the heart and can cause restrictive cardiomyopathy. It is associated with connective tissue disorders. So all connective tissue disorders, or like important ones like scleroderma, they definitely have some kind of damage to the heart, and even in old age, diastolic malfunction is fairly common. Now, once we are aware of these causes of heart failure with preserved ejection fraction, we need to see what can be done for management of these patients. Just to strike, or rather to make you imagine how this patient is going to look like, I'm going to write a rare presentation or rare cause of this endomyocardial fibroelastosis. Just look at the name, fibroelastosis. That means fibrosis in the heart, and as a result of it, the hemodynamics will definitely be compromised. Another one can be hemochromatosis. So we need to understand if there's a stiff heart. You see, the last two examples that I've told you are simply telling you that there is stiffness of the ventricles. There is fibrosis in the ventricles. So they're not as compliant as they are. If the ventricles are not compliant, if the filling of ventricle is compromised, again there is pooling of blood in the lungs. At this point of time, I can give one more example. Suppose I give you an inflatable toy. You can fill air in an inflatable toy. It could be Spider-Man, it could be any toy, it could be a small ball. You can fill air into a balloon, party balloon ball, and the ball or the balloon will expand. But if I say with your mouth, try to fill air into the tire of your car or of your bike, is it possible? No, because the tire is very stiff. Because the tire of your bike and car is made of rubber, it is very stiff. With my mouth, I cannot fill air into it. The point I'm trying to say is, in patients of heart failure with preserved ejection fraction, the ventricular function is compromised in a sense that it is not causing any systolic malfunction. It is just that it is not able to relax properly because it has become relatively more stiff. The best example that I can give you for heart failure with preserved ejection fraction would be try filling air into the tire of a car with the mouth. It's practically not possible. I mean, you might have pneumothorax trying to do that, but your lungs will never be able to deliver that kind of pressure that can be delivered at a petrol pump to fill air into the tire of your car. So the stress on your lungs is the one that I'm talking about at the moment. Similarly here, guys, when you talk about heart failure with preserved ejection fraction, and he says what drugs would be given for this condition, don't talk about ACE inhibitors and beta blockers. Yes, we will talk about them in people with reduced ejection fraction. At the moment, we're talking about major drugs that reduce mortality, and there are only two of them. The first one of them is aldosterone antagonist. One of them is gonna be, obviously you can understand by this junction or this point of time that I'm talking about spironolactone, because spironolactone can cause a bit of gynecomastia in males. So you can use eplerenone, no issues. It is aldosterone antagonist which can be used to neutralize the damage to the heart. And second is ARNI. When I say ARNI, you very well are aware from the pharmacological domain that we shall be using a combination of valsartan with sacubitril. And both of these drugs are extensively asked in the exam, especially sacubitril has already been asked a couple of times. When I talk about these two drugs, please remember valsartan would anyway be angiotensin receptor blocker, so it will neutralize the increased effect of angiotensin 2, which is contributing to increased stress on the heart. But sacubitril per se will be a nephrilysin inhibitor. And well, what does this nephrilysin inhibitor do is that it inhibits the degradation of BNP. Remember the same BNP that was being produced due to volume overloading. If you are going to inhibit the degradation of BNP, then it will cause more natriuresis, and if you cause more loss of salt and water from the body, then the stress on the heart of this person will gradually reduce. So in the exam, if they ask you what is the best drug for management, he is basically trying to tell you that these are two mortality reducing drugs, because the best drugs are only the ones which reduce the chances of death. No, end point is reduce 5-year mortality, reduce 10-year mortality. That is gonna be ARNI and aldosterone antagonist in that order. I mean, it's unlikely that he'll ask you only one single one, because in Harrison both of them are given together. So whether you write ARNI first or aldosterone antagonist really does not matter. The bottom line, guys, I want to highlight is simply the fact that when I say mortality reduction, the only two of them that have been found to be successful here. Please appreciate, ACE inhibitors will treat hypertension, but they'll not treat the heart failure caused with hypertension. To treat the heart failure caused by hypertension, either use ARNI or use aldosterone antagonist per se. And if you treat hypertension in early age groups, then this is not going to happen. No, this is the same guy with hypertension. When you told him, sir, you are hypertensive, you have to take medicine for the whole of your life, and when you told that diagnosis at 40 years, he was laughing at you and he's saying, no, I'll go to Ayurveda, etc. The same guy now, because he will go into heart failure due to diastolic malfunction, will be having nocturnal awakenings because of the pulmonary edema component. So that is why we went into research and said, okay, what are the drugs which can treat the heart failure associated with hypertension? So there are two separate questions, guys. If he talks about a guy with hypertension, I agreed, you can use ACE inhibitor, beta blocker, no problems. But when it comes to hypertension induced diastolic malfunction in the heart, then please do take care of this issue in the exam, because you see, when we read hypertension associated heart failure with preserved ejection fraction, we tend to focus more on the word hypertension and we start thinking, okay, less than 55, more than 55, more than 55 CCB, less than 55 ACE inhibitor. I mean, that's the thought process of ours, and we are trying to miss out on what the examiner is asking. That is, he wants to see, are we aware of the diastolic malfunction associated with patients of uncontrolled hypertension in the long run? The next diagram is very aptly describing what I've just explained to you, that in a patient of heart failure with preserved ejection fraction, where you have a stiff heart, two drugs are going to try and win the battle for you. That is going to be ARNI and aldosterone antagonists. And to prove this, I also have a reference from Harrison, which I just want you to at the moment see on the screen. It is clearly mentioned that digoxin is ineffective. I showed this snapshot one to give credibility to what I'm saying in second. You see, whenever we are studying pharmacology, the first drug that is taught for heart failure is digoxin. But please remember that digoxin can actually cause a marginal increase in oxygen consumption of the heart, which can be detrimental to a person in a sense that already there is shortage of fuel. For example, if somebody is having coronary artery disease or somebody is having left ventricular hypertrophy due to long-standing hypertension, then already there is stress on the heart, as a result of which digoxin will rather worsen the patient. The only two drugs, as you can see, that I've highlighted in color orange and are beneficial for the patient are AA and ARNIs. It is not even written that they are 100% effective. They have just mentioned the fact that they are beneficial. So as far as the battle for management of patients with heart failure with preserved ejection fraction is concerned, the battle is still to be won. We are obviously on the winning side, but we have not won the battle completely. So a lot of research is required actually on these patients. I will now be explaining to you what's going to happen in a patient of heart failure with reduced ejection fraction and what is the approach that you would be following. First and the foremost, I would like to mention some important causes. Like, for example, a person is having triple vessel disease. I had suggested him to undergo coronary artery bypass grafting, but this patient had very stubbornly refused this surgery. Or I can give a medical reason also, like in diabetic patients there can be diffuse disease, that is every few millimeter or every few centimeter there is multiple blockages present. So how many will you bypass? I mean, the number of blockages are so many in a diffuse coronary artery disease that there's a limit to how many bypasses can you be actually achieving. As a result of it, sometimes if you read the word diffuse coronary artery disease, CABG might actually not be possible in these cases. Similarly, when I talk about a hypertension patient, it can result in heart failure with reduced ejection fraction. On this, the query again is, sir, you just said hypertension causes heart failure with preserved ejection fraction. Now you're saying it is causing reduced ejection fraction. Well, the concept is, guys, that if I say somebody is having a long-standing hypertension, he has been having this hypertension for 20-25 years. There's a development of left ventricular hypertrophy. That is where I'm talking about HFpEF, preserved ejection fraction. But if I say that somebody has recently developed hypertension due to kidney problem, like this person has suffered from glomerulonephritis, maybe PSGN or RPGN, in those circumstances, if it is a recent onset hypertension developing in a patient because they would be low GFR, there would be a stimulus for RAS, the sudden increase of blood pressure can actually contribute to acute presentation as well. So hypertension, long-standing, causes heart failure with preserved ejection fraction, and recent onset, short duration, severe hypertension. And renal hypertension is always very severe, so it can definitely result in the problem that we are discussing. Then can be the valvular conditions that have been discussed in the earlier section of the app, which can range from valvular aortic stenosis in the long run, or let me say mitral regurgitation. Even from the pediatric domain, if a person is having left to right sided shunts, conditions like VST, conditions like PDA can cause a biventricular failure. The next cause can be cor pulmonale. Now, this could be having two reasons. One could be a chronic presentation with COPD, or it could be acute presentation that is encountered with pulmonary embolism, like the person was having deep vein thrombosis, the clots went into the right side of the heart, then landed in the pulmonary artery. And once the clots will cause physical blockage of the pulmonary artery, then blood of the right ventricle can't go in the pulmonary artery. And right ventricle being relatively, I would say, weaker when it comes to the muscle component. Left ventricle has a lot of muscle, right ventricle has lesser amount of muscle, so it can fail very fast. So if I say the word acute cor pulmonale, it basically implies that there is an acute onset right ventricular failure due to a clot in the pulmonary artery of the patient. Then would be some miscellaneous causes like Chagas disease. You very well know the fact Chagas disease can cause HLA cardia. It can contribute to mega esophagus and a mega heart as well. Sometimes can be mega colon as well. Another condition that I'm just writing for completion's sake can be person who's having multiple episodes of tachyarrhythmias. I can say tachycardia induced cardiomyopathy. The point is that if a person has not taken treatment for the chronic presentation of arrhythmias, like for example, a person is having atrial fibrillation recurrent episodes, then the treatment available for these patients is ICD, implantable cardioverter defibrillator. But if a person does not get the procedure done again, because there's a fast beating of the heart, so in the long run, it can contribute to heart failure as well. These are the important causes of heart failure with reduced ejection fraction, and I just want you to compare these with the causes that I've explained to you for patients having heart failure with preserved ejection fraction. And hypertension is one thing that is common between both of them. I've already explained the concept. Long-standing versus a recent onset hypertension will make a marked difference. Now let us look at what is the drug approach that will be useful for management of these patients. So I'm going to create two scenarios for you. One is a person who's having volume overloading, and this is contributing to acute pulmonary edema. The person is having extreme amount of breathlessness. The SpO2 on admission in room air is, let me say, only 80%. So in these circumstances, the first and the foremost thing that you need to do is provide oxygen to the patient. And to give this oxygen, well, the best method would be not to use a routine nasal cannula or a routine mask, because gas can easily diffuse out. So it always makes sense that in patients who are having acute pulmonary edema, the person should be made to sit up in the hospital bed, and you can use a tight fitting face mask that is non-invasive ventilation. This will definitely improve the oxygen saturation of the patient. Apart from oxygen, we need to give Lasix to the patient, that is a diuretic. I want to reduce the pulmonary edema component by using loop diuretics in this case, though I know that they can be concomitant hypokalemia if I use large dosages of furosemide, but I'm ready to actually, let me say, bite the bullet, mainly because at the moment the patient is in bad state. Well, the mnemonic that you can use, in fact, this is the only mnemonic that Harrison has used as LMNOP. I mean, Harrison gives you a lot of text, but he's given you a mnemonic that is LMNOP. So Lasix, morphine, nitrates, oxygen, and positioning. Well, as far as morphine is concerned, I want to highlight why are we giving morphine for a person of pulmonary edema, because if you read pharmacology, it says morphine causes shunting of blood from pulmonary to systemic circuit. Please appreciate here I'm not giving morphine for relief of any kind of chest pain, and I have a lot of agents apart from morphine to relieve chest pain. I am giving morphine to this particular patient. Why? Because I simply want to reduce the pulmonary edema component. If you read pharma, morphine is obviously an effective analgesic, but it also reduces pulmonary edema component by shunting of blood from the pulmonary circuit to the systemic circuit. Then I will be also ensuring proper positioning of the patient. The hospital bed can be definitely adjusted so that the legs of the patient will be relatively lower and the head would be relatively higher. And over and above this, I also need to give nitrates to the patient. Now listen to this part very carefully. The reason why you're giving nitroglycerin in a drip format to your patient is because it will reduce the preload, afterload, dilate the coronary artery. So it's a win-win situation, because the heart needs to be rather given a little bit of rest. What I mean by given a little bit of rest is that if you reduce the afterload, if you reduce the preload, then the stress on the heart, the workload on the heart is dramatically reduced, and therefore it will be able to function relatively better. The pumping action of the heart will remain the same. But if you reduce the preload and the afterload, then it will be better at clearing the pulmonary edema component developing in a patient. And lots of time in MCQs, instead of nitroglycerin, they might actually mention a new drug by the name of nesiritide. It is not that new, but I would say just in comparison's sake, he can talk about the traditional nitroglycerin drip, or he can talk about nesiritide infusion being given in the patient. Now the advantage of nesiritide is, I mean, what is it gonna do? So this will behave like BNP in the body. Earlier I was teaching you in ARNI, I was inhibiting the breakdown of BNP. So BNP will work for longer duration. In this case, I can say this is purely a BNP analog, and because it will behave like BNP, it will cause natriuresis, and that is the advantage of this drug, because you wanna kick out the extra salt and water, and all patients of congestive heart failure are anyway having secondary hyperaldosteronism. Therefore, they are already having more salt, more water in the body. If I kick out the salt and water, it will definitely reduce the problems for this patient, in a sense that the volume overloaded state of the person will definitely become lesser. There are a couple of new drugs which are also mentioned. For example, he has mentioned regarding ularitide or serelaxin. As far as these are concerned, serelaxin, ularitide, the results have been, very plus minus. So I have just mentioned them, but as such, they're not very, I would say, groundbreaking or very earth-shattering kind of news that's gonna be working magic in case of heart failure. But you can now see a very interesting entry here, for which I again get a lot of queries from my students saying, sir, we have read nitroprusside is useful for management of malignant hypertension. We use it for patients who are having very high BP, and the snapshot that you showed from Harrison was mentioning not only necessitide but was showing nitroprusside also. Why nitroprusside in this case? Well, guys, nitroprusside will also cause reduction in the preload and afterload. Now, after all, it will dilate the blood vessel. So, if it will reduce the load on the heart, as I was saying, heart is under stress. What do? You reduce the preload, you reduce the afterload. So, the contractility is going to remain the same, but at least now the functioning on, I would say, the mechanical part would be better, that it will be able to clear the pulmonary edema component. Once it settles down, obviously, we'll be also concerned about the fall of blood pressure. I agree to that these drugs can cause a pretty precipitous fall in blood pressure, and it can be counterproductive because that can decrease the coronary blood flow. But that is what we doctors do. No, it is literally like walking on fire, or I would say catch-22 situation. I mean, if you use too much of it, there's a problem. You use too less of it, there's a problem. So it's like walking a very thin line, walking on fire, I would say, when you are using this drug. So I can just mention the name once again, that is sodium nitroprusside. So I just want you to remember 3 N's here, that is nitroglycerin drip, necessitide, nitroprusside. Any of the 3 can be given, and the reason why I'm using this is mainly to reduce the load on the heart and improve the efficiency per se. The mnemonic that you can use to remember acute pulmonary edema manifestation is LMNOP. Let me give a practical cause of acute pulmonary edema in a person. This person was suffering from COVID-19. Obviously, COVID-19 will cause non-cardiogenic pulmonary edema, but COVID-19 has also been documented to cause COVID-19 myocarditis. So, though there are various causes of myocarditis, from the recent illness, I can say COVID-19 myocarditis per se can contribute to acute pulmonary edema and can cause decompensation of congestive heart failure in the person. Now, I want you to compare acute pulmonary edema versus a patient in whom there is cardiogenic shock. Like, for example, a person has had a myocardial infarction, there is a stunned myocardium. Now, stunned myocardium will not be able to offer the right amount of contractility. So, when I say the word pump failure, it basically means, pump failure is what I would be using rather a term to explain to non-medico family members. For me as a doctor, I am talking about cardiogenic shock. Why does a person of cardiogenic shock actually go into shock is because there is a dramatic decrease in the coronary blood flow of the patient. And the reason for this coronary blood flow reduction is mainly that the contraction of the heart is reduced. You see, after all, when heart is contracting, then there is no coronary blood flow. Coronary blood flow is maximum during the phase of diastole. So the heart is getting less fuel, it is getting less nutrition. I definitely want to get this patient out of this mess. Now reducing preload or afterload will really not matter. What you need to do at this junction, I repeat the fact again, if it is volume overloading, yeah, you need to give diuretics. You need to reduce preload afterload. But here I'm not talking about any volume overloaded state. All I'm saying is that the person's cardiac muscle is not able to pump the blood effectively, like post-myocardial infarction. In those circumstances, I will have to use vasopressors so that I can manage this patient relatively better. Now, when I talk about a person who's having cardiogenic shock, one of the important vasopressors that is always to be used is norepinephrine. And again, the query that comes is, sir, in pharmacology, we studied about dobutamine. So yeah, dobutamine will definitely come in the discussion. But if I just follow Harrison, you will notice that first it is norepinephrine and then it is dobutamine. Why so? Why so? Because if you look at the mechanics behind functioning of norepinephrine, the main advantage of norepinephrine is that it enhances the diastolic blood pressure, not systolic. If I will increase the systolic blood pressure of the patient, it will definitely contribute to worsening, because already the cardiac muscle post-MI stunned myocardium is not able to function properly. You increase systolic blood pressure, you are killing the muscle. But if you increase the diastolic blood pressure, you will be able to upgrade the coronary blood flow, and that is the basic root of the problem. No, the problem is less coronary blood flow. If I try to increase it, that's going to be advantageous for me. Dobutamine, yes, is used, but remember, dobutamine causes beta 1 stimulation. If you will cause beta 1 stimulation, what will happen? Heart rate will increase. If you increase heart rate, what will happen? Oxygen consumption will increase. Oxygen is already in short supply, man. If you're gonna put stress on the heart by straight away giving dobutamine, it can be counterproductive. So you will notice that when you follow the algorithm for management of pump failure or cardiogenic shock or even septic shock. In fact, I just want to make a remark here. Even when you will read about septic shock, you will read about fluid resuscitation having a limited role. Vasopressors have a major role when it comes to septic shock. I mean, even if you give fluids to a septic shock patient, it will not make any difference to the blood pressure. One of the important aspects for management of septic shock is again vasopressor, and the first one that is given in the textbook is norepinephrine. Another one that can be used is obviously dopamine, and the advantage of using dopamine will be that it also improves the renal blood flow, because it will act on the receptors in the kidney also, D1, D2. So if it will increase the GFR, it will prevent renal failure also, because lots of time you will read cardiogenic shock patients will go into renal failure. I want to prevent that. So combination of these can be used, but the first one that should be used for management of pump failure cardiogenic shock is what I just highlighted. That is vasopressors are going to be the first, I would say, weapon that you have to fight this battle. Over and above this, they can test your knowledge regarding even inodilators. When I say inodilators, there are multiple drugs that will be coming to your mind. So I can say two aspects for inodilator. One, if you just focus on the word ino, it means increase in force of contraction. Dilator means the load on the heart is less. So it is best of the both worlds. You are increasing the power, but you are reducing the load per se. Repeat once again. I mean, inodilator, you are upgrading the power delivery to the engine. Engine will work better. And if you reduce the load on the engine per se, or let me say if the friction is reduced, then the car can run definitely faster. So the multiple inodilators available, that is milrinone and amrinone, and they're especially useful if it is the right side of the heart that is compromised, because then if you reduce the load with respect to the pulmonary artery, then the right ventricle will be able to function relatively better, and therefore the pulmonary blood flow of the patient will increase. And you very well know that if right ventricle will fail, remember inferior MI, right ventricle will fail, so even BP of the left side will fall. I mean, traditionally BP should fall with left ventricular failure, no, but even right ventricular failure in inferior MI, we do a fluid resuscitation. Over and above this, there are a couple of newer drugs which are given, so I'll make a mention of those, like levosimendan. Another one will be omecamtiv. Now, when I'm talking about omecamtiv, they definitely can, touch on the pharmacological domain. The same MCQ, add one of the choices from pharma can say, this is mechanism of one of the drugs, and it might actually say that all are correct about management of congestive heart failure, except. So, what does omecamtiv do? It causes increase in the speed of ATP hydrolysis. What it ultimately is doing is, the end product in single line will be that it will result in production of a stronger actin-myosin complex. I repeat the statement once again. The end result is this formation of an effective coupling, effective bonding of actin-myosin, so the contraction will be relatively better. So production of a stronger bond, I would say, or a production of a much more, effective bonding between the two, and therefore the cardiac contractility will definitely be enhanced. These are the usual drugs that we will be using. Now, suppose he says a person is having, I'm changing the slide now, medically refractory cardiogenic shock. You have used all the firepower with all the drugs that I have highlighted before you, but unfortunately, in this person, the central venous pressure is still elevated. You know very well cardiogenic shock is one variety of shock where central venous pressure is always elevated, because in hypovolemic shock you will always be having a less CVP, but cardiogenic shock central venous pressure is grossly elevated. So fluids absolutely have no role in management of cardiogenic shock. It is mainly vasopressors that will help in this case. Now, if he says medically refractory cardiogenic shock, you have used all the drugs that I've discussed, then you will be calling in an interventional cardiologist, and this interventional cardiologist will be explaining to you regarding Impella or regarding IABP, that is intra-aortic balloon pump. These are devices which can be deployed. These are implantation devices, external battery powered devices that can take over the contractility of the heart and enhance the coronary blood flow of the patient. What I have today explained to you is when it comes to acute congestive heart failure in a person, then it implies that the person's cardiac output is dramatically reduced to less than 40%. In preserved ejection fraction, I was using a cutoff of 50% or more. That means that person might come to your OPD walking, but this person will be severely distressed. When I say reduced ejection fraction, the person is usually incapable of walking in. Most patients will be brought into the casualty on a wheelchair or on a stretcher. And obviously, the survival of these patients will be in doldrums. Now here there can be two possibilities, whether the person is going into cardiogenic shock or whether there's a volume overloaded state. For volume overloaded state, I can give a scenario from Indian domain, like this lady, she's severely anemic and her hemoglobin is very, very less, and she's maybe in the last trimester of a third or fourth pregnancy. You can understand pregnancy itself is so demanding on the body of a lady. If she's pregnant for the third time in last, let me say, 4 years, and she's having a hemoglobin of 5 or 6, then her heart is definitely gonna fail during labor. So in those circumstances, if I'm going to have a volume overloaded state, I will definitely use diuretics, position the patient, use nitrates. Whereas when it comes to cardiogenic shock, I shall be using vasopressors in the patient and save this person. If required, implantation devices like Impella, or I mentioned regarding IABP, intra-aortic balloon pump, can be used. Now, assuming the fact that in both the cases there is a clinical recovery, you have got the patient out of that situation where the lungs were filled with, or the alveoli were filled with fluid, and the person could not even talk. I mean, even every word was a torture for the patient. Patient was unable to speak. But now you have got this person out of this, rather the patient has made a dramatic recovery. The same patient who could not talk is at least next day or the next to next day sitting up in the hospital bed, and maybe when you go to the bedside, when he looks at you, he gives you a smile. Now this person will definitely be discharged from the hospital after a few days, but will not ever have a normal cardiac function, because if there is a post-MI cardiogenic shock, then because of the hypoxic damage, that part of the heart is, not going to be able to contribute to cardiac contractility. So the heart will always be having a suboptimal output. The ejection fraction of this patient at the time of discharge, post-discharge, in follow-up OPDs will always be lesser than normal. So what are you going to do in a person of acute congestive heart failure at the time of discharge or post-discharge is again initiate these patients on ARNI. Please remember the fact that ARNI is gradually becoming the number one weapon that we use to fight heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction, especially when the person has been discharged after the acute event, which we thought he may not survive because he maybe came with a pink frothy sputum. The drugs I've already highlighted before you. You will be definitely be able to neutralize the effect of angiotensin 2, and you would be potentiating the effect of BNP that will cause natriuresis, kick out the salt and water, and you are on your way to recovery. Now here I want to tell you that when I was a student at your age, or let me say when I was teaching 2 years ago in face-to-face classes when there was no COVID, I used to teach my students that the first line drug for chronic congestive heart failure is ACE inhibitor and beta blocker. The way I've written the data, you can very well see that if all of these drugs that I've explained at the moment on the slide are given in the exam, you will first mark on ARNI, because that is how it is given in Harrison. Is mentioned a diagram in which is mentioned role of ARNI in both heart failure with preserved and reduced ejection fraction. The older data was A plus B. They also did studies to see what should you introduce first. Should you first introduce beta blocker? Should you first introduce ACE inhibitor? That does not matter. Whether A is introduced or B is introduced, either of the two can be introduced first. The point is, when you compare, when you do a head-to-head comparison, when you do a meta-analysis, then ARNI has been having a better reduction in the mortality. Additional drug that I would like to mention here will reduce the edema component. That will be both pulmonary edema and as well as pleural effusion, as well as ascites, as well as pedal edema, will be aldosterone antagonist, that is spironolactone. So you will notice that in people with heart failure with reduced ejection fraction, when they move on to the chronic phase, that is when the two drugs that I initially mentioned, ARNI and aldosterone antagonists, are common, and over and above this, ACE inhibitor and beta blockers have also been mentioned. And you will notice, like if you are going to see prescription slip of lot of patients of chronic CHF, it might be still mentioning ACE inhibitor, beta blocker. There's no problem with that. It's not that ACE inhibitor, beta blocker is not causing a reduction in mortality. Lot of cardiologists are still writing ACE inhibitor, beta blocker only. It is just that when they've done a head-on comparison, there have been a few percentage points better reduction in mortality with ARNI as compared to ACE inhibitor with beta blocker. So that is why I have emphasized that would be one of the important answers in the question. And because of lots of overlapping data that came up, I will have to mention this topic of heart failure for one last time towards the end in a comparative mode, where I'll just try to sensitize you to the minimal aspects that you should be knowing. I know you have studied regarding drugs for heart failure lots of time when it comes to pharmacology, but my focus has been a little different from, I have not tried to go the conventional pharmacology way by teaching you regarding digoxin. I have tried to tell you what is actually done. In patients with heart failure with preserved ejection fraction, the best example is this guy is with long-standing hypertension. He neglected his health substantially long to cause a hypertrophy and a stiff ventricle. So there's a diastolic malfunction. So we will start this person on ARNI and aldosterone antagonist. Obviously, stepwise would be done. Initially, ARNI, if there's a partial response or no response, AA can be added. And subsequently, obviously, lots of patients will get benefit with the combination of the two drugs. Now we're going to talk about heart failure with reduced ejection fraction. There can be two possibilities. One, he can talk about severe acute pulmonary edema due to volume overloading. This could be a severely anemia patient, especially like from the OBGYN domain. I'm saying severe anemia with congestive heart failure, third trimester of pregnancy, and maybe this is her third pregnancy. Another could be development of cardiogenic shock. So the approach will definitely vary, whereas we will be using vasopressors. IV fluids are not going to be given in any patient having acute pulmonary edema or cardiogenic shock, but vasopressors are the mainstay of treatment on the right, with obviously Impella coming up subsequently and LMNOP on this side. And now I have highlighted that these patients are going to get discharged. Now on discharge, what are you going to write for these patients? So first answer is ARNI, and subsequent one is ACE inhibitor with beta blocker. I know it was a repetition, but I have deliberately kept this slide because on a single slide, when you compare the data, and that is the approach that I want you guys to remember, that whenever you wanna read any topic, when you read that in comparison, it definitely will give you relatively advantage, or you will relatively feel more comfortable when you compare the topics. Additional drug that I can mention for chronic heart failure that actually affects the funny current. You see, funny current is what is important for genesis of human life, because that is what makes the SN node active. So the current that is important for genesis of life, funny current, is the one that is affected in this case, that is ivabradine. Ivabradine has been primarily used for management of patients of chronic congestive heart failure. Now suppose he mentions that the person is having refractory congestive heart failure. Now listen to my words with a lot of care, guys. I'm not saying refractory cardiogenic shock. I said refractory congestive heart failure. That means you've done everything that I've taught in the previous slide. Still the person is not improving, including maybe Impella was deployed in the person. The first device that I can use for these patients is LVAD, that is left ventricular assist device. So though medical science is years away from manufacturing an artificial heart, but then we haven't definitely been able to replicate the function of a left ventricle by putting this device to the original heart of the patient and try and enhance or augment the cardiac contractility. The brand name for this is also very, I would say, heartwarming. I would say HeartMate. Then the second thing that is important, especially from dilated cardiomyopathy perspective, is that left and the right ventricle may not contract at the same time. So if, let me say, the right has contracted and has sent blood towards the lungs, but the left part of the heart is still to contract, so there could be pooling of blood in the lungs. See, both ventricles should contract together. If there's going to be asynchronous contraction, then there will definitely be pooling of blood in the lungs. And what we can do is put in two electrodes, one electrode in the left ventricle, one in the right ventricle. Now the computer will control the firing so that the both ventricles of dilated cardiomyopathy patient will contract together, which is called as CRT, cardiac resynchronization therapy. This is slightly different from the concept of pacemaker. You see, pacemaker will mainly be controlling multiple chambers of the heart. Here what we are doing is we are controlling two, left and the right ventricle, whereas when it comes to a pacemaker, usually it's a triple lead pacemaker where we tend to control three chambers of the heart. That's going to be the left side of the heart is also controlled. Obviously from the right hand side we'll control the right ventricle so that it can send blood into the lungs. But if you are having three leads going to the heart, that three leads is pacemaker. If it is two leads, that is cardiac resynchronization therapy. That is just like from an X-ray you can get a fair bit of idea of what kind of device is present. I mentioned two, though obviously an X-ray cannot differentiate what device is put on the left side of the chest of the person. But if you see three leads, it's usually going to be a pacemaker. If you see two leads, it is going to be CRT. Obviously, in patients with cardiomyopathy, if you've exhausted everything that I've discussed, the last resort for these patients of medically refractory CHF is cardiac transplantation. Please attempt the question with care. This is refractory congestive heart failure. And prior to that, I told you regarding a person who's having medically refractory cardiogenic shock. And there's an overlap, obviously, so that is the reason for lots of confusion that might come in. But there is a couple of important aspects for the topic of heart failure that I wanted to remember. I was trying to talk about digoxin also, guys. I did not mean to be disrespectful for digoxin. That is the drug that opened our eyes towards the world of congestive heart failure, that at least we can treat patients of heart failure. Otherwise, those patients in earlier years were deemed to be gone because the main pumping organ is not functioning. But why I would say I put digoxin lower down in the entire hierarchy level is mainly that digoxin is capable of causing arrhythmias. One of the important arrhythmias that is asked with digoxin toxicity is ventricular bigeminy, and another one that can develop is non-paroxysmal atrial tachycardia with a varying AV block. Please remember the fact that these two statements that I mentioned are themselves MCQs. If he says what is the most common arrhythmia seen with digoxin toxicity, it is ventricular bigeminy, for which you will again have to answer. I mean, if he says what is the drug treatment for ventricular bigeminy, you would be using lignocaine in the patient. And in non-paroxysmal atrial tachycardia with AV block, the heart rate is usually normal, so no treatment is required. So I criticize digoxin, or I put it on the lower value as compared to the drugs, mainly to sensitize you to the fact that it is a pro-arrhythmogenic drug, and already we are dealing with so many problems when it comes to heart failure that we are more comfortable using the newer category of relatively safer drugs. So do brush up the pharmacology domain of congestive heart failure, and then listen to this discussion once again at 2x so that you can have a better perspective of the aspects that I've said before you. Thank you for your patience and hearing me out.